So Dr. Miller is a professor of pediatric endocrinology at the University of Florida. She graduated with her MD from the University of Florida in '98. This is where it's the yourself thing. And her MS in clinical investigation from the University of Florida in 2005. She's the principal investigator for several medication trials for individuals with PWS and also works on medication trials for individuals with hypothalamic obesity. She followed several hundred patients with PWS and several with Schaaf-Yang syndrome as well. Not on here, but Dr. Miller is the GOAT as it relates to PWS and SYS. Yeah, that's right. Yeah, that's right. Michael Tan is a registered dietitian, certified diabetes educator in the Division of Pediatric Endocrinology at the University of Florida College of Medicine. He specializes in Prader-Willi syndrome, pediatric obesity, and both type 1 and type 2 diabetes. In 2005, he earned his BS in biological food engineering with minors in food science and human nutrition and a master's or material science and engineering from the University of Florida as well. He works closely with Dr. Jennifer Miller, has been in his current role helping families with PWS since 2018. And Michael, I gave the group a little preview yesterday when we came down and we went through your nutrition stuff. Dr. Miller taught me, yeah, sorry. What would Michael Tan do when looking at things to eat? And I got to say, I've failed more times than I've passed. So that's right. Yeah. What would Michael Tan do? Yeah. So. Yeah. Right. And the natural GIF is not. Michael Tan would not approve of the natural GIF. So, without further ado, Dr. Miller. Thank you. Thank you.
All right, good. I'm loud. It's a small room. Sorry. I find that insulting.
No, if you wanted to.
Yeah, it's all good. Mike might want it. He's not as loud as me. All right, so as mentioned, we are going to go through nutrition and endocrine issues in Schaaf-Yang. I do want to qualify this to start with, that while Mike and I do consult with doctors all over the world about how we treat patients with Schaaf-Yang, it is a lot of consulting. We actually have somewhere between 5 and 10 patients, probably closer to 5, that we see regularly with Schaaf-Yang. We often see people one time get medicines started, and then their endocrinologist will continue the medicines once, I've discussed all the risks and benefits with the patients, and they go back and then we don't see them again really, other than at conferences. So we do have, I'm just going to be upfront with you that we do have somewhat of a limited scope of knowledge, but I think everyone does at this point with Schaaf-Yang. It's a relatively new Emma. I'm going to take that gun. It's your last warning. I'm coming for it. And so as I go through this, you're going to hear me say like more is needed to know about this and more we need to know about that. I always tell my patients that to me, the best kind of doctors are the doctors that are willing to admit to you what they don't know and what they do know and not try to pretend like they know stuff that they don't really know. So Mike and I have never pretended like we don't know stuff that we don't know. So we're going to tell you, where our limits are as I go through this so that you are aware. But a lot of those limitations are honestly because there's just not a lot of data and there's not a lot of research at this point in time. And we're hoping to change that. These are my disclosures. Mike has no disclosures, but I get research funding from drug companies. Okay, so we're going to talk about endocrine issues and out of my way, sorry. We're going to start with oxytocin, which I know is probably one of the hotter topic areas for a lot of youngsters with Schaaf-Yang syndrome. And then we're going to talk about growth hormone, thyroid hormone, puberty hormones, adrenal issues, and then 2 different kinds of diabetes, one called diabetes insipidus and one called diabetes mellitus. And I'm going to end with hyperphagia, and then I'm going to turn it over to Mike to discuss diet and management of diet. Maybe I'm going to do that. If I can make the slide advance. Is it advancing? No. Go. Move. Why is it not moving? I've just moved it manually, but if you tell me push the button, I'll smack you. So we are going to start with oxytocin, as I mentioned. So this is a very complex diagram from one of Christian Schaaf's papers about Schaaf-Yang, demonstrating all the different things that happen as a result of the MAGEL2 mutation, which, as you all know, is the pathologic cause of Schaaf-Yang syndrome. And the two things that oxytocin hopefully can help manage or touch for people with Prader-Willi syndrome. The first is the feeding difficulties. All of you know this. When the kids are babies, it's very difficult to feed them. A lot of them end up with tubes. A lot of them end up having difficulties with chewing and swallowing and coordinating all that stuff all along, from infancy. It can be a problem. And then the other thing is autism spectrum disorder features. As you all know, autism spectrum is a very common feature in Prader-Willi syndrome. And as you probably may have read, people have investigated oxytocin use for autism for a while now. And it's an interesting thing, oxytocin. So, we know that early in life, oxytocin, your exposure to oxytocin actually does make a difference, and has long-term effects. And so we know that during prenatal development and at the time of birth, if you have adequate exposure to oxytocin, it will influence your ability to feed, it'll influence your IQ, it'll influence behaviors. And so specifically autism type behaviors. And it is, potentially the idea is that that oxytocin will improve your neuronal networks. Oxytocin signaling is actively involved also in motor and sensory stuff. So we were talking about Hayden being on oxytocin, and the motor skills have developed remarkably. Yeah. So it's got other features besides what I think everybody thinks about for oxytocin, which is pro-social bonding, right? That's what we think about for oxytocin, which is great from the point of view of autism spectrum symptoms, but from other parts of life, there are other positive effects of this medication that we don't talk about very often and people aren't really looking at. It does seem plausible that there is specifically a critical period during which you can rewire the whole system. And so we know that, for example, when babies are born and they have a brain bleed from a traumatic delivery, or they have lack of oxygen during their birth or whatever, that those baby brains are so malleable that they can work around those areas of deficit. And often by the time they're a little bit older, you never know that there was any problem. And that's the idea here, is that if you could hit early enough with oxytocin, that potentially it could help rewire the brains of individuals with Schaaf-Yang and sort of overcome some of the deficits that are there because of the genetic mutation. So again, this is from Christian Schaaf, and his thought process here was that 0 to 5 year mark is probably the time. It's probably the critical time of hitting people with intranasal oxytocin in order to help with brain rewiring and brain growth and things like that. And he thinks that after 11, it may not be nearly as beneficial. Now, this is a theory, right? I mean, it's a theory. We don't know this. We haven't tried. We don't, because Schaaf-Yang was identified really pretty in the scope of life pretty recently ago, right? We don't have a lot of data on older individuals and whether or not treating them would make a difference. So, again, it's a hypothesis. It's not proven. So.
Feels like a good time to get your saliva taken so that we can do more research on it. Yeah.
Not right now. Stay. Good plug, but don't send people. Are you saying that I'm boring? Is that what?
When Michael's speaking, go get it.
So again, the idea behind that diagram I just showed you from Christian is that the brains of infants and toddlers are more neuroplastic. They can work around stuff better. If you introduce oxytocin early on, that it will help potentially more than it would help if you introduced it older. But again, we don't know. So I don't think I would take that for anything. I mean, I wouldn't say that if your kid is 14, that should let you say, we can't try it because our kid's too old. You know what I'm saying? Like we just don't know. We don't have the data. And so, the other thing that's interesting that I put up here because I think it's interesting is that oxytocin also plays a role in temperature regulation. which we all know that kids with Schaaf-Yang have issues with temperature regulation, and muscle tone, which they have issues with. So again, something to speak to the fact that this could potentially be an efficacious treatment for kids. We know in kids with Prader-Willi that intranasal oxytocin given in the first 3 months of life seems to improve sucking and swallowing. We don't know that in Schaaf-Yang. We have no idea. And because the referrals I get for infants, they're all still in the NICU, right? And I say, try it. And then there's never any follow-up. So I have no idea what has happened to those individuals and how well or poorly they have done, or if it even made a difference. So a registry would also be a freaking fantastic idea, so that people could put these things into a database where people could look. Because again, I do think it would be helpful for parents to come further, behind you, to have this information available, right? I mean, because you guys are the pioneers right now, really, I mean, because it's just so young. Again, more studies are needed. Now, I wanted to talk really briefly about oxytocin just in general. Oxytocin is a hormone that is what we call a self-fulfilling prophecy. It is a rare type of hormone that will upregulate its own receptors. So you give oxytocin intranasally, it gets into the brain, it binds its receptors, and then it will get inside the cells of the brain, the glial cells, and it will upregulate more oxytocin receptors so that you can, eventually you put all the receptors that are available onto the surface of the cell to receive oxytocin. Once those are all bound up, if you continue to give oxytocin, you flood the system, and it binds to what we call arginine vasopressin receptors, which are very similar in design to oxytocin receptors. Those receptors you don't want to bind. Those receptors cause aggressive behavior, paranoid behavior, temper tantrums, things like that. So part of the problem with all of the autism studies that have been done with oxytocin, because that's where you're going to go, right? For knowledge and literature, for your kids, you go to the autism literature. And the problem is that those studies have flooded the brain with oxytocin. They're giving like 8 times the amount of oxytocin that other people give in different studies. And there was no real reasoning behind that. It was just, people, unfortunately, because there's not a lot of data, make up doses and say, this looks good. Let's try this. Well, that works. So let's try that, And again, everybody with autism is different. So just like everyone with Schaaf-Yang is different. So you can't assume that you're going to do the same dose for every person. So my point about oxytocin is you want to dose low. You do not want to dose high. If you dose a lot, and give multiple times a day, the chance of overloading the system and causing problems is high. So I'm just giving you that sort of warning and knowledge. And it's one of the issues, I'm sure you saw downstairs that there's a carbetocin trial going on for Prader-Willi. And carbetocin supposedly only binds the it's very selective for just the oxytocin receptors. But remember what I just told you, that when you bind those receptors, they upregulate their own production. And so eventually the same thing is going to happen, and you're going to bind those arginine vasopressin receptors over time, and you're going to end up with problems. So I'm just saying, use with caution. All right. And then, there's been a ton, as you all know, of major tube mouse models and studies done in the mouse model, but I really, really think that now is the time that we have to start translating into humans. I mean, we've got 0 trials as far as I know, right? I mean, nothing. And those of you who have known me for a few years know that I've been pushing, right, for these drug companies. I'm like, this has to be, like, we have to do this. Nobody wants to touch it with a 10-foot pole, which and again, their argument is we just don't know enough, but that's why we do research, in my personal opinion, right? Is so that we can learn more. All right, now the whole rest of this is going to be about the hypothalamic pituitary disorders. So the MAGEL2 gene is absolutely critical for development of the hypothalamus and pituitary gland. And those are the hypothalamus is your master control gland in your brain that regulates appetite, weight, sleep-wake cycle, temperature regulation, pain perception, all the things. And it then drives the release of hormones from the pituitary gland that regulate thyroid, growth hormone, stress hormones, puberty hormones. So that's what we're going to talk about it. Okay. So who's taking my survey for me? You, right? Who's going to count hands for me? Somebody was going to count hands. All right. Somebody count hands for me. Ready? All right. Whose child had low blood sugars, whether in the NICU or at some point documented? Just 1, 2, okay. Has it? Okay. Somebody that works with Christian Schaaf wants to look at this in a little bit more detail in terms of the cause of the low blood sugar. So growth hormone deficiency can cause hypoglycemia. We're going to talk in a minute about adrenal insufficiency, which also can cause hypoglycemia. But we don't really know if these are the causes of hypoglycemia or if it's something innate to this MAGEL2 gene problem that causes issues with pancreatic insulin release, and that actually causes hypoglycemia. Again, all new stuff needs to be looked at because we don't know what we're doing. We need to have more understanding. 48% of babies with Schaaf-Yang will have hypoglycemia. And again, that can be seen with growth hormone deficiency, but it's not necessarily due to growth hormone deficiency, and we just don't know. We do know that 50 to 60% left to their own devices will have short stature if we don't intervene at all. But studies have shown that height will increase significantly with growth hormone use, and specifically in Schaaf-Yang, the BMI will go down with growth hormone therapy, and it goes down because you're losing fat mass. You're maintaining lean muscle mass, you're losing fat mass, and that holds. The longest people have been on growth hormone at this point is 4 years, and it's held for those whole 4 years that there's an improvement in body composition. So patients and their families reported an increase in muscle strength, endurance, and several families noted beneficial effects on behaviors, which is great. Okay, so here's the tricky part, right? You all know this, that Schaaf-Yang is not an FDA-approved indication for growth hormone therapy. Endocrinologists are really good at being tricky because we've had to deal with growth hormone for 25 years now. And so I don't suspect that many of you have issues with endocrinologists getting your growth hormone for your child. Just saying, just requires a little sneakery. Thyroid issues are next. So thyroid issues are super common in genetic disorders. About 30% of people with any kind of genetic disorder will have hypothyroidism. And they're also super common in hypothalamic pituitary disorders. And again, it's about 20% there. So there should be a lot of people with Schaaf-Yang that have thyroid issues just based on those two things, genetics plus disruption in the hypothalamic pituitary axis. And yet I couldn't find very much at all in the literature. We have one adult, I think, that's on thyroid hormone at this time, and that's it. Like nobody else is on thyroid hormone. But again, it should be there. So what it suggests to me, the sort of paucity of information that's out there and treatment is that we're not looking correctly. So when doctors check for thyroid dysfunction, they check a TSH, normally thyroid stimulating hormone, which comes from the pituitary gland. And in all the rest of us, that's fine because it'll tell you if your thyroid's working or not. With central hypothyroidism, though, which is what this would be, TSH should be normal. It's the thyroid hormone floating around in your blood that's not normal. And so I would say to all of you that if you've not had this done, and you should have it done at least once a year, to have a free T4 and a total T3 as well as a TSH, because it's important. And I think we're probably very likely missing it in some way because it's just not out there in the literature. And thyroid hormone is that a blank slide? Oh, I did that. Thyroid hormone is really important for brain development. So it's something that should be watched. All right, now we're going to talk about sex hormones. Okay. And so one of the main features in Schaaf-Yang is incomplete development of the sex organs. So testes in men, breast and vagina and ovaries and uterus in women. In the mouse models of MAGEL2 mutations, there's reduced fertility, both in males and females. There's abnormal menstruation in the female mice, and the male mice have low testosterone levels. As of this point, this week, bless you, hypogonadism, which is underdeveloped sex organs, is reported in only 15 to 25% of women and in 55 to 65% of men with Schaaf-Yang. I can't believe that's true. It's got to be the same number of women as it is in men because it's the same thing, and so again, I think we're not looking. I think that sometimes, when, especially for women, like men, it's a little bit more obvious when things are not going the way that they're supposed to go. But if somebody said to me, well, your kid's not having a period yet, I'd be like, okay, yeah, that's fine with me, So I just don't know that we're reporting it, that we're looking for it. And so I'm just saying it's something to just be aware of. What typically happens in Schaaf-Yang that we've seen is it's not that there's absent puberty. Most of the kids do, oh, all wet. Most of the kids do start puberty and get somewhat of the way through puberty, but not everybody finishes puberty completely. And so you just need to know this, to watch for it and make sure the endocrinologist watches for it. So what that means is those women who have, delayed puberty or, cessation of puberty too early will likely require estrogen therapy, to help pubertal development, and the men may require testosterone supplementation. Now, take home is that second sentence on there. There have been reports through puberty that individuals with Schaaf-Yang may have problems with aggression, anxiety, and mood disorder during puberty. So be aware. Okay. I'm not saying that the estrogen or testosterone would actually necessarily cause those problems, but we know that when men and women with Schaaf-Yang go through puberty on their own, there's been reports that there are some mood volatility that happens during that time. So I'm just making you aware so that if it comes to a point where your child does require estrogen or testosterone supplementation, that you're aware of what the potential risks are with that supplementation. It is done because of bone health. We're going to talk about bone health as the very last slide. Yes, ma'am.
What would be that hormone therapy would start
13.
13?
Okay, adrenal issues. Again, this is super lowly reported, so I don't know how much of a problem it is, but we do know that that the cells that drive the function of the adrenal glands, which are what make your stress hormones in response to stress in your body, are smaller and underdeveloped in the brains of people with Schaaf-Yang. Again, it's not reported much at all, but I can say this to you, it's never, this problem is never found in isolation. So if you have no other pituitary hormone dysfunction, so you don't need growth hormone, you don't need thyroid hormone, you don't need sex hormones, it's very unlikely that this is going to be a problem for your kid. However, if your kid does need those things, this is the one piece of this that can be deadly. Okay, you don't want to miss it. Okay, and so you're going to know that this is so the problem with this is to diagnose it, the tests are crap. Okay, they give you false positive and false negatives. That's why we don't do them very much, because they're kind of crappy tests. I mean, what is that going to do for you? So what we do personally is we tell our patients to just be aware. And if the child is, God forbid, in a car accident, going to have surgery for something, really sick, and in the ER, ask somebody to check a cortisol level. Cortisol is your stress hormone, to see what it is. And even if they don't do that, have them give steroids. It never is going to hurt your kid to have them get steroids if they're sick or in surgery or something like that. It could hurt, like kill your kid, to not get steroids if they need them. And the signs of adrenal insufficiency are low blood pressure, low blood sugar, and high heart rate. So like dehydration is what it looks like. Really severe dehydration associated with something that shouldn't be. Yeah.
Cortisol level before or out.
So I recommend doing it at induction of anesthesia, because that's the time of the stress on the body. So I have them place the IV, start the induction, get the cortisol level, then get steroids.
Okay.
How often does that work out?
Yeah.
They get the steroid. That's what I did.
Let's keep the steroid.
Yeah, exactly. If you're not there, you have to trust other people. Okay, diabetes insipidus. This is one we don't see super often either, fortunately, but and this one is really just more of a pain and quality of life than anything else. So diabetes means urine, insipidus means water. So the kind of diabetes that you're used to hearing about, we're going to talk about next, which is diabetes mellitus, sugar urine. Okay, this is water urine. Okay, and so it's caused by a deficit in a hormone called antidiuretic hormone that sits in the posterior part of the pituitary. It's made in the hypothalamus and sits in the posterior pituitary to be released when you need it. It helps regulate your salt-water balance. People with Schaaf-Yang who do have diabetes insipidus, fortunately, have so some people who have this because of a head injury or a brain tumor or whatever don't have a normal thirst mechanism. It's really pain in the ass because you have to really closely monitor their sodiums and water intake. Your kids actually do okay with this because they will drink and pee and drink, pee and drink and pee, to keep their sodiums normal. It's just awful because they drink, pee and drink, pee and drink, and that's bad for anyone's quality of life. So it can be treated very easily. There is a replacement hormone called DDAVP, which is a long-acting version of the antidiuretic hormone. It can be given as a sub-Q injection, tablets, or a nose spray. So if your kid is drinking a lot and peeing a lot, something to just watch for. If this is what if this is what you're suspicious of, the urine, again, water urine, it's gonna be super light colored. It's not gonna get dark even, after you've been all night. Oh, I lied. Diabetes is not next. Prolactin and dopamine is next. So prolactin is another pituitary hormone that can be abnormal in Schaaf-Yang. And so a lot of atypical antipsychotic meds, which are used for behaviors, can also cause an elevated prolactin. A sign of an elevated prolactin is actually lactation from the breasts. So if your child has any kind of breast discharge at any time, that needs to be evaluated. And there are treatments for this. So it's discharge from the breast, it's mood lability, and it's weight gain that's unexplained. Those are the things you worry about with prolactin. The problem really, more than anything else, is that there is an inverse relationship between prolactin and another hormone called dopamine. Dopamine is really important for control of mood and behavior, and also for motor control and coordination. So knowing that, you want to watch it. The one you can't measure dopamine, but you sure the heck can measure prolactin. So you want to watch for it and make sure that if you ever see any concerns, that they are addressed by your endocrinologist. Interestingly, high prolactin in autism has been related to repetitive and stereotypic behaviors, which I thought was interesting because we do see that a lot as well in Schaaf-Yang. So, and this is not something, as I was preparing this talk, I found this and I was like, oh, I have not been doing that. So I think we should be doing it. Okay, type 2 diabetes. We talked about briefly, it's sugar urine. And the reason for type 2 diabetes in Schaaf-Yang is actually not obesity or increased body fat. Because like I said, you go on growth hormone, your body fat actually goes down pretty significantly. It's the fact that this darn gene also influences the development of the beta cells of the pancreas, okay? And so you can get disruption of insulin release from the beta cells of the pancreas. We see this in Prader-Willi as well, because MAGEL2 is involved in Prader-Willi syndrome as well, and we see disruption of insulin release from the pancreas as well. So like I said at the beginning, when we were talking about hypoglycemia, it could be growth hormone, it could be adrenal problems, or it could be disrupted insulin release from the pancreas. It would be post-meal that you would see this, because the thought is that it would cause increased insulin release in response to a meal. So like 3 hours after a meal, your blood sugar might drop and you feel awful, tired, hungry, whatever, shaky. So just, this is just something to be aware of. And then there's also a risk of glucose intolerance in type 2. Like I said, it's higher in Schaaf-Yang than in the general population. All right, almost done, I promise. So hyperphagia, which you probably heard about a ton at this conference, the unmet need to consume food, is less common in Schaaf-Yang than it is in Prader-Willi. It's only about 25% of those with Schaaf-Yang. And when it happens in adulthood. It doesn't really happen in kids very much at all. And interestingly, just like Prader-Willi, there are high levels of the hunger hormone ghrelin from the beginning, from infancy. Ghrelin is your hunger hormone. It makes you hungry, produced in the stomach. Really high, higher even than Prader-Willi, which is high. The problem is this: I don't think it's real. I don't think that the ghrelin is actually causing the hunger, because the kids, this, they're your kids. They're not excessively hungry as kids, right? I mean, and so I think it's a smoke signal. And what I've always said in Prader-Willi as well is exactly that. It is a smoke signal. It tells us there's something wrong at the level of the hypothalamus and pituitary, and those gut hormones are not able to get through the blood-brain barrier to signal correctly to the brain, because the hypothalamic and pituitary receptors are not there for them. So it's not something that you should worry too much about. Again, I just think it's a sign that there's something going on. And then bone health. Yes, you may.
So the new drug that came out, FICAD,
Yeah.
what is that attacking there for hyper?
Insulin, beta cells.
Beta cells, okay.
So see why it would work in Schaaf-Yang, like I've been saying for 2 years now.
Got it. And then so these new GLP-1 drugs that are coming out, so they won't work. Why is?
Because the hypothalamic receptors are not there. So GLP-1 is another gut. If ghrelin is high, telling you that there's not enough hypothalamic receptors for gut hormones, GLP-1 is another gut hormone.
Wait.
Got it.
No.
That was.
She got something cool.
Oh.
Actually,
Hannah, was there something you had to say right now? You good? Yeah, she did good.
She did. Yeah.
Yeah, you did good. Again, this MAGEL2 gene is a super important gene, also important for normal bone development. We all know that arthrogryposis or joint contraction is very, very common in Schaaf-Yang syndrome, and bone mineral density is often very low in people with Schaaf-Yang. Here's the problem. Again, adults, how long has this been, out there as a syndrome? Not very long. And so adults that we see with Schaaf-Yang who are having DEXA scans done to look at their bone mineral density never had growth hormone. They never had sex hormones. They never had a diagnosis, right? And so we don't know what the natural history is going to be for younger kids. We just don't. And so I think that story remains to be told, but I do think that it's important to know that bones are impacted by this gene mutation. And so that your kids should start having DEXAs in adolescence around 16 to 18 years of age and monitored every 2 years with DEXAs to watch bone mineral density. There's medicines to treat bone mineral density that are easy to use. And then the other thing that's really interesting is scoliosis. So scoliosis, as you probably have heard, is commonly seen in Prader-Willi, also pretty commonly seen in Schaaf-Yang. So you need somebody who knows what they're doing to look at your child's back on a regular basis. Because the scoliosis is very similar to what you see in Prader-Willi in that it starts out as a twisting of the spine. It's not that curve that you see on x-rays when people talk about scoliosis. It doesn't look like that at the beginning. It just kind of looks like this. And so, so you need somebody to be checking the child's back and to be getting x-rays at least once a year to make sure that if there's scoliosis present, that you're doing something about it. And that is all. And I'm gonna let Mike talk next, and then you can ask. I would start, Chase. So that's a very good question. So the scoliosis in Schaaf-Yang actually is an adolescent scoliosis, just like you would see in the general population. So you don't have to worry about it in infancy like we do. Well, at least not that we know of. We haven't seen it in young children with Schaaf-Yang yet. Okay, but we do know that it happens in adolescence with Schaaf-Yang. So definitely peripubertal time starting around 8. That's considered peripubertal in today's world. Hold on, Mike, I'm getting yours.
I think you've already opened that.
Did not.
There you go. Thank you.
Mhm.
Okay. Hi, everybody. Thank you, Dr. Miller. You're not leaving, are you? Okay, good. Anyway, good morning, everyone. My name is Mike, for those of you who don't know me. I'm the dietitian who works with Dr. Miller. I work with Dr. Barry here as well in pediatric endocrinology at the University of Florida. Okay. So just a brief overview of what I'm going to talk about. So of course, I'm going to talk about how to keep our kids as healthy as possible, as long as possible when it comes to nutrition. So I'm just going to kind of give you a guideline, a breakdown of how I think the best way to feed our kids. So you can see there, I'm going to talk about my nutrition recommendations. I'm going to talk a little bit about convenience. I'm going to talk about special occasions, how our families play a role in all of this, and then a summary at the end. So the first thing I kind of want to say is that Schaaf-Yang, eating with Schaaf-Yang, to me, in my opinion, is really not a super unique, it's not super different than how we all should be eating. I do, however, believe that it is more strict. And the reason why it's more strict is because it's more critical to follow, right? There's more consequences here. So bone health, Dr. Miller talked about, she talked about the risk of type 2 diabetes. Of course, there's hypotonia, the possibility of hyperphagia. So there's multiple reasons why it should be more critical on following a good, healthy diet. So again, it's really not terribly different than how we all should be eating, but it is much more strict and more critical to follow. Everything here is based off of the Mediterranean diet. Oh, yeah, okay. Um,
But
here, yes, yeah.
Yeah.
Okay, perfect, thank you. Okay, yeah, so everything's based off the Mediterranean diet, which is there's a boatload of research behind the benefits of the Mediterranean diet. Number one, quality. Of course, we want good, high quality food. Number two, the correct portion sizes. We all want the right amount of food. Number three is balance. So we want the right amount of food in the right proportions to each other. And I'll explain a little bit what that means throughout the presentation. And of course, we also want some variety as well. So in our world, in my world, I don't think of food in terms of the traditional food groups or the food pyramid or anything like that. I think of food in terms of these three categories. Number one, protein. Everyone knows what protein is. That one's pretty obvious. So meat, fish, chicken, etc. Number two, I categorize non-starchy vegetables. I'm not talking about starchy vegetables here. I put that into that third category, but non-starchy vegetables, of course, are things like, think of your salad bar type thing. So broccoli, lettuce, spinach, tomatoes, green beans, etc. So non-starchy vegetables, number two. Number three is complex carbs. So your starchy vegetables are actually in category three. So carbohydrates or complex carbohydrates. That would include grains, and your starchy vegetables, and anything like beans or legumes. So I think of food groups as these kind of main categories. So of course, we do not want refined grains. Refined grains is just a fancy word of saying white flour, white bread, your regular pasta, white rice. So we do not want these. Again, not because, well, mainly because they don't provide much nutrition for us. Yes, they taste good. Yes, they go well with a lot of different meals and snacks, and they're very abundant, but they're not providing much benefit to us at all besides just very quick, easy energy, but is not helpful in many ways. So we really want to avoid these as much as possible. Unfortunately, most of the foods you buy, or most of the foods you can easily find in the grocery store and at restaurants and food trucks, are refined grains. So it is a little bit harder to find these, but they are available. Potatoes, that's a very good question. That would fit into the complex carbs, into the starchy vegetables. So that's a very good question, actually. Potatoes are not evil. I think potatoes are completely okay. I do not put potatoes into the same category as white bread, white rice, etc. So I would rather you have potatoes on your plate than white rice. I'd rather you have potatoes on your plate instead of white bread. Yes.
That's two pets, so I blend everything for him. And then grill of potatoes, you have to cook them before you can blend, or with blending them, break them down enough? Just,
I would cook them.
I always do, but I'm like.
Yeah. I don't know for sure, but
What?
yeah, that's another good point. Yeah. Yeah, I think I would cook them with the skin on. Another kind of caveat to that, that's a very good question. Now, if it's like or if it's like a processed potato, like Pringles, or veggie straws are basically just potato starch. So if it's like a processed potato, I would put that into the refined grain category. But if it's just regular potato, you buy a potato from the grocery store and you chop it up or mash it up, that's completely okay. To me, that is better than, that is not a refined grain. Potatoes get put into that same category, which I don't believe is accurate. Of course, it limits excessive added sugar, sweets. This is a big thing. Again, might be obvious to some people, might not be obvious, but we do not recommend any sort of sweetener at all. So whether it's natural or artificial, okay? So any additive that is added to food to make it taste sweet, we would not recommend. So that includes stevia, monk fruit, etc. Yes. Yes. Yeah, it would include.
Too, and it's like such a good carb.
Well, it definitely makes it taste
For
good.
volume.
Oh, I see.
It's too fat. Yeah, like he's not tasting it. So you
It's not tasty, but I wonder what the response from the data cells that eat them. So,
Yeah.
so gluten.
Yeah, it's still getting it.
Yeah.
Good to know.
Yeah, no, that is a good question. But yes, generally, sweet tasting foods is severely restricted. These are examples of sweeteners. I bolded the ones that are the most common. Those are the ones you'll see most commonly. And this is not an all-inclusive list. You'll likely see other sweeteners out there that exist and new ones come out all the time. But those are the ones we definitely do not recommend. Fruit. Okay. So fruit is a interesting topic. So fruit, of course, does taste sweet. Fruit does have some nutritional benefit, of course. It's got vitamins, it's got minerals, it's got fiber, it's relatively low calorie. However, we do limit fruit. So because it is sweet tasting, it does have sugar in it, and it can easily be overconsumed. We don't recommend, well, I'll start there first. So we recommend fresh only. I do not recommend any sort of processed fruit. So you can see examples there. Canned fruit, dried fruit, applesauce. We have a new audio tech. Any sort of processed fruit, I really would not recommend. Once you process fruit, it does lose fiber, it does lose nutrition, and typically is much sweeter than when it is fresh. Twice a day or less, so 1 or 2 times a day is our recommendation. So 3, 4, 5 times a day, that's definitely too much fruit. Portion sizes are small. So if it's a banana, I would recommend the length of your finger. So for me, a banana's, yeah, of whoever's eating the banana, yes. You're not eating my finger size of banana. Yeah, so if it were me, a banana would only be maybe half of a banana. For other types of fruit, our general recommendation, just to give you a point of reference, is kind of whatever fits flat in the palm of your hand. So in the palm of my hand, blueberries, I might eat like 8 or 10 blueberries. That would be a serving. Again, I could only have 0, 1, or 2 servings of fruit a day. So limited portions, limited portion sizes, limited frequency. And it is important, in our opinion, just in terms of blood sugar and insulin response, to always serve it with protein. Again, this goes for everybody. I mean, I try to do this, my own girls, my wife, etc. I always recommend eating it with protein. So I wouldn't want just fruit alone. Just snacking on strawberries is not a balanced snack. So I would recommend strawberries plus almonds, or strawberries plus a cheese stick or something. So very, very, very common foods that you find in the grocery store, very common foods that you yourself might buy or that we see often are basically flavored yogurts. I'll just bring up the whole list here. Flavored yogurts, flavored oatmeals, bars, granola bars, protein bars, cereal bars, breakfast cereals. Almost all breakfast cereals are sweet in one way or another. A lot of condiments like ketchup and barbecue sauce are sweet, very sweet. So these are very common foods that I'm sure a lot of people probably eat in here, but we do not recommend these, okay? And just kind of a rule of thumb, what I recommend to almost everyone I talk to is just trying to eat something that is savory instead of something sweet. So instead of like Honey Nut Cheerios for breakfast, how about, scrambled eggs and toast? Instead of pancakes and syrup, you can have peanut butter toast. Anyway, so a more protein focused and more savory foods when you think about your meals and snacks. And instead of a granola bar, you can have a cheese stick. Instead of flavored yogurt, you can have cottage cheese or plain yogurt, and you can add a little bit of fruit in plain yogurt. Okay. So these are examples of foods that do have some sugar in it, but are still okay. So our recommendations here are based on sweet taste, not sugar as an ingredient. So there are foods with some sugar in it. Sorry, there are some foods with sugar in it that are okay because these foods don't taste sweet. So these foods, even though there are what does it say there? There's 2 grams of sugar in plain Cheerios and 1 gram of added sugar. It's still okay because it's not a sweet food. Now, if you were eating plain Cheerios, I would recommend eating that with some sort of protein. So a small bowl of plain Cheerios plus scrambled eggs or a piece of sausage or something like that. So when it comes to grains, as I was saying before, we don't want refined grains. So when you're looking at the grocery store, what to buy, look for whole grains. The key word there is whole. Don't look for, if it doesn't say whole grain, it might not be whole grain. So again, what I was saying in my presentation yesterday to Prader-Willi, just because it says multigrain doesn't mean it's whole grain. That doesn't mean anything. So the reason why we don't want refined grains is, again, is because it's not nutrient dense and it's also not filling at the same time. So those are just examples. I have started over the past couple of years, cassava flour and tapioca flour, specifically cassava flour. I've seen that more and more. It's a way that these food companies can add. It's basically, it's different than white flour. It's lower carb, so you can like market a product as being lower carb without adding white flour. And it on the surface, it might seem healthier, but there's really, to me, I put it in a category called fluff. All of these things I put in a category called fluff, meaning it's there, but it doesn't add any sort of benefit. To me, I call it a book with no words. A book with no words has no meaning. It has no value. So cassava flour has no value. White flour has no value. Now, it might not have anything quote unquote bad in it. Like there's no detriment, there's no harm in it, but there's no benefit at all either. So look for 100% whole grain. So I do want to say portion sizes are challenging, not challenging, but it's very different. I don't know how many people are in this room, maybe 50 people in this room, but there might be 50, all 50 of us might need different portion sizes. So really what you see there in bold, the most important thing is that your child is growing appropriately and gaining weight at an appropriate rate. You know, not too fast, not too slow, not losing weight when they're not supposed to, et cetera. So portion sizes can be very variable, but generally are going to be probably smaller just because of the hypotonia, et cetera. Because of essentially the low muscle mass. And you see there fruit, I talked about fruit a little bit already. So snacks, I don't want you guys to assume a snack is needed. I don't want you to pre-plan any snacks. I kind of want I want your child to be able to go with the flow as much as possible. So having a breakfast, lunch, and dinner is completely fine, but I don't like people to schedule meals, schedule snacks, giving snacks all the time, or I don't want there to be any sort of habit or black and white schedule here. Just because I think it's best for people to eat naturally. Like if you're hungry, eat. If you're full, stop eating as best you can. I don't want people to eat just because the clock is telling them to eat, just because they think it's time to eat. To me, I call that feeding the clock. I don't want you to feed the clock. I want you to feed your body if you feel like your body needs it. So like I said there, if your child is easily distracted, so if your child might be asking for food or signaling for food, if you can easily distract them, to me, I don't think they're truly hungry. And they may be just bored, or they may just have a craving for food, but not necessarily true hunger. So going back to carbs, to me, carbs are important. I don't want carb-only snacks. So I don't want snacks to be just cracker. Like even if it's a good whole grain cracker, like a Triscuit or something like that, that Triscuit has to be balanced with some sort of protein. Carbs should always be balanced with protein, whether you're eating it at a meal or a snack. There should always be some sort of protein there. And like I was saying, please try not to schedule snacks. So in terms of balanced meals, so we talked about quality of food. Of course, we want good, high quality food. We don't want refined grains. We want to try to minimize how much processed fruit we're eating. And we want good, complex, high fiber carbs. And then we want a little bit of fat too. Fat is not a bad thing. I know fat is high calorie, and a lot of times we do focus on calories because we're afraid of excessive weight gain. I don't focus too much on calories, and I don't want you to either. I want you to focus more on balance. So your meal should look something like this. So some sort of protein, whether it's chicken or steak or fish. I want a lot of vegetables. Vegetables to me should be essentially the biggest thing on the plate. Too many times people think of a lot of people forget about vegetables completely. And people who don't forget about vegetables, it's really just an afterthought anyway, but it really should be the main focus here. So I want lots of non-starchy vegetables, some protein, and then a little bit of carb. Carb is a very tricky topic. Most people eat too much, and then some people get too scared of carbs, and then they go too low. I see families on both ends of the spectrum here. So really, I don't want to demonize carbs, but I also acknowledge that it is very easy to have too much. But please don't do keto, don't do low carb or anything like that. Of course, I don't want carb heavy either. I don't want carb focused meals. So spaghetti as your meal, that's too carb heavy. So think of carbs as a side item, not the entree and not nothing either. In terms of fats, unsaturated fats are best. Unsaturated fats typically come from fish or plants. So fish or olives or nuts or seeds or oils. That's going to be your best source of fat. In terms of balance, there's just two kind of pictures here of different ways that I think of balancing meals, balancing snacks. Again, really what this comes down to is having some good carb, lots of non-starchy vegetables, and then a good source of protein. And again, when I make sure if it is a starchy vegetable, it would go into the carbohydrate category. But yeah, feel free to take a picture if you want, but I know, again, this is being recorded as well. I do think variety is really, really important. Many people eat the same foods over and over and over again, and that leads to things like selective eating or picky eating. It can lead to nutritional deficiencies. So you might just be eating the same nutrients over and over and over and over again, but missing other nutrients because you're not eating a large variety. So I do recommend the parents, please don't rely too heavily on your favorite foods. You know what your child's favorite foods are. That's perfectly fine, but don't serve those just over and over and over again. And do not be afraid of serving new foods and different foods and foods your kids don't like. Keep serving those, even if they're not eating them. The repeated exposure will get them to essentially get used to that food over time. And don't let your kid rule the roost. Like I tell parents this all the time. You are not a waiter, you're not a waitress, and your child is not a customer. Your child is not, you're not serving them. So don't be afraid to serve foods that you know they might not eat. Again, the repeated exposure can get them used to it. So like I was saying before, a good variety ensures that you're properly nourished and that you minimizes the risk of any sort of deficiencies in nutrients. And that also encourages a good gut microbiome and also reduces the risk of any sort of potential selective eating or picky eating. Drinks is super, super critical. I talk about drinks with 100% of the patients I see. It's typically the #1 area where people are getting sweet stuff. So I highly recommend just not offering, not serving any sort of sweet drink. And again, that includes like your diet type stuff. It includes your Pepsi Zero, Vitamin Water Zero, Crystal Light. I mean, there's thousands of different drinks out there that are 0 calories, 0 sugar, but they taste sweet. And that still affects our body. It affects all of our bodies in here. So unsweetened drinks is highly, highly, highly recommended. And once you start sweet drinks, it is very difficult to get off of them. So like I was saying before, being careful of clever marketing. Just because something says no sugar, no added sugar, and no artificial sweeteners, that doesn't mean it's not sweetened. Because when they say all 3 of those things, that they say no calories, no sugar, no artificial sweeteners, they're probably adding stevia or monk fruit, because those are natural. So you can still say all those things and still sweeten it some way.
To me, like, I'm just trying to push more water to conservation issues. So maybe it's an alternative, well, it's not carbonation, just like that, but like just something to get more water than just plain water.
Yeah, so there's a lot of different flavored unsweet teas. So, I mean, if you go to the, like the tea section of your grocery store, there's dozens of different flavored teas that should be unsweetened. So that sometimes works. You can squeeze a sour fruit into the water, whether it's a lemon, lime, grapefruit, something like that. You can do unsweetened milk alternatives, like unsweetened almond milk, unsweetened oat milk. You can do regular milk too. That's completely okay as well. To me, the biggest thing is that fear of constipation, while I acknowledge is legitimate for sure, but I think people get a little too scared of it, and then they get off of the water too early and then start offering sweetened stuff because they know their child will drink the sweetened stuff, and they understand that the fluids obviously help with constipation. But at some point, for most of the children we talk to, or most of the families we talk to, if you're pretty strict about it and not offering the sweetened stuff, your child will typically acknowledge that and typically get used to that. But if they know that you would give in, if they know that I'm going to refuse this water because I know my mom or dad's going to give me a sweetened drink eventually, they're more likely to refuse the water. So I know it is a tricky balance for sure. It is hard. But what I tell all families is do what you think works best for your families. But yeah, there are some alternatives. I would try the unsweet tea or lemon or lime, or there are lots of carbonated options now, but like you said, she doesn't like carbonation, so I mean, that's okay too. But it is a tricky balance for sure. Oh yeah, hint, it's on that picture. I know it might be small, but it's right here. So it's basically just water with a hint of a fruit flavor without the sweetness. The earlier you start, the better. So the younger your child is, better it's time to start. But I mean, don't give up if your child is a little bit older, that's fine. But try to start this habit as early as possible. This is just a meal idea list. It's not a meal plan. Just ideas for meals, right? So every single meal here you see is a good source of protein, has some carbs. It's not, none of these are carb heavy. None of these are carb dominant. And then every single lunch and dinner has a non-starchy vegetable. There's a little bit of fruit here. And there's nothing sweet here besides the small amount of fruit. Okay, so these are just examples for those of you who don't like cooking or don't like spending time in a kitchen or are just short on time, which I'm sure everyone here is short on time. I like to remind families that it is okay to I guess what I want to say, you can still make a balanced meal without actually cooking. So you see there, for example, breakfast would be peanut butter and whole grain toast. Lunch is some deli meat, some Triscuits, and some carrots. And then dinner might be some tuna, whole grain bread, and sliced cucumber. And that's okay. There's literally no cooking there, but you can make balanced meals even without cooking. Okay, so just examples of convenient, easy foods there: steam and bag meals, canned beans. You see the minute quinoa there in the bottom right. And nuts and seeds. Nuts and seeds are really, really good, easy, convenient choices for protein, especially if you're a vegan or vegetarian. Snacks. These are just easy, convenient snacks as well. If you're looking for packaged, like on the go, easy snacks. Sorry, I'm gonna go back. I would say that any of the carby ones, consider the Smart Food popcorn a carby one, the Hippies, Anyone that's kind of starchy, I would eat that with protein for sure. So whether that's sunflower seeds or almonds or cheese stick or something like that, balance carbs with protein. Special occasions, so we're not saying completely zero on treats and things like that. We're not saying no cookie ever. We're not saying no muffin ever, no cake ever, but it is of course limited. It's much more strict than you or I might eat special occasion foods. So my recommendation there is I want it to be a true special occasion, like a big birthday, a big holiday, or a vacation, something like that. So these are just examples of occasions that are not truly special that we have heard in the past before. So yeah, Wednesdays is probably my favorite one. Yeah, or after dinner. That's yeah. So no, yeah, yeah. So yeah, these special treats are okay, but yes, it is very, very strict. But yes, please keep the definition of special to be truly special. Family roles. So like I was saying at the beginning, this is how we all should be eating. I mean, try to treat this as a team approach, because that's the best way to do it. It makes no sense to me when parents start treating other people in their family differently, and you know, mom or dad might be making 2 or 3 different meals because everyone is picky. Just do your best to try to have it all the same. So don't, and like I was saying all before, do not cater. I wouldn't highly recommend not catering to your child's preferences. Treat all children similarly. Don't let your own food preferences determine what's being served. So a lot of parents might be picky. And typically, picky eating parents end up with picky eating children. So try not to make that connection. Just because you're picky, try not to let that spill into your children. Do we have any grandparents in here? Grandparents are infamous for showing love through food. It's very, very common. My recommendation is it's okay to show love, absolutely, but not through food. You can show love in many, many, many other ways. Okay, just a quick summary. Of course, we want high quality food. The key takeaway there is really, really, really trying to avoid any sweet tasting food, and that includes any sort of sweetener, whether it's honey, whether it's stevia, whether it's monk fruit, sucralose, anything. So good, high quality, non-sweet food. Quantity, again, quantity is very variable, but typically a little smaller than most people. We want a balanced meal. The right amount of, to me, getting the right amount of carbs is probably the hardest here. So not carb heavy, but not keto or low carb either. Good variety. Okay, so try not to rely on the same foods over and over again. I like to recommend the families just to kind of keep a good flow of variety is whenever you go to the grocery store, just trying to buy one thing that you haven't bought in a while. So, and maybe one thing that you've never tried, or one thing that you haven't had in a couple months.
And so it would be seasonal vegetables, which a lot of times it was all stuff we kind of do, but then it was definitely a good variety of smart.
That's perfect. Yeah, that is perfect. Yeah. Another good thing, again, to remind you, again, just don't be afraid to serve food that your child doesn't like. Okay, I mean, most parents do this, but with my girls, I continually serve foods I know they don't like, and that's completely fine. I don't force them to eat it, but I just have it on their plate. And I don't care if they don't eat it. If my daughters tell me, I don't like this, I don't want it, I'll say, that's fine, you don't have to eat it.
Do you have a dog?
I used to have a dog, but yes, having a dog helps, for sure. Yeah. I do have a hungry cat. Yeah, yeah. Drinks are really hard. Again, I know constipation is a big underlying factor in this, but please try your best to only offer unsweetened drinks as much as possible. Convenience, you don't have to make anything fancy. special occasions for special foods, and family roles. Remember, parents, you are in charge, your child is not in charge. And that's it. Yes,
So like.
thank you.
A lot of our kids are food driven. Similar to Prader-Willi, but like, so it's like, the clock does determine when they can have a snack. Would you suggest that we maybe just have a drawer and fridge and in the cupboard that like, instead of having the clock dictate when they eat, it's just a free for all? No, scares me, but like.
Yeah, no, not a free for all. I do understand. Yeah, a lot of your kids are kind of clock focused or food focused. But yeah, if my recommendation on if your child is asking for a snack or signaling for a snack, and you are kind of questioning, I don't think you're really hungry, I would just offer something really light. And what I mean by that is like cucumbers or. That's a good idea too. To me, the number one strategy would be trying to distract, but if they're still consistent, yes, water and something super light. So if they're munching on cucumbers, that's fine. That's really not that big of a deal, right? Cucumbers or celery. But if they're so persistent on it where you actually do think they are truly hungry, then yes, you can offer a more robust snack. But number one, just try distraction. Number two would be just a really light snack and water. And then number three, if you do think they're truly hungry, then you can offer like a real snack. Yeah.
We're off the YouTube after 11 years, but it's taking longer to eat than calories in the gym. So like any tips on making feeding vegan, not quicker, but like, I don't know, it's just taking
A long time.
a long time. And so she lost weight since this has happened.
That's a good question. Is it because of,
Chewing.
yeah, is it
Chewing.
yeah. And I'm assuming you're making things easy, chewable sizes and stuff. Yeah.
As he eats out, and we have a hard time getting enough calories. You know, the nutritionist says he needs so many calories a day, and we're like, okay, we actually really achieve that, but we're not supplementing formula. We should be eating a little bit healthy.
Yeah, no, that's a good question.
We can help you balance diets.
So yeah, so if you're looking for more calorie dense foods that are easy, so the first thing that comes to mind is liquid. So milk or a higher fat milk, like a whole milk.
Like
Yeah,
that, avocado.
avocado, great one. Nut butters, if there's no allergy, nut butters, oil. So just being more liberal with oil, olive oil when you cook or sprinkling it on the food. So oils, avocado, dairy and cheese and eggs. MCT oil would be fine. That's very good, easy calories. It's beneficial. Yeah, so I'll just try to make it more calorie dense using those types of things. Yeah, I hope that helps. But yeah, I would focus not on sweet stuff, of course, but yeah, but the fats, good fats like avocado, fish, eggs, dairy, nut butters, yeah. So I would try that more, make those meals a little more dense in terms of those foods, yes. Any other questions for me or possibly Dr. Miller?
I'm listening with like a,
No,